Morning.
Morning, sir. I'm audible, sir.
हेलो. हाँ, आप जस्ट ज्वाइन. हाँ, ठीक है. थैंक यू. यस. कैन वी स्टार्ट?
Yes, sir.
या, प्लीज.
Uh, Patient is a 22-year-old female. He is from Bijnor, UP. She presented with the chief complaints of difficulty in swallowing for past. History of presenting illness. Patient gives alleged history of accidental consumption of toilet cleaner on 12th of September, that is 2 months back. She had consumed around 50 ml approximately, followed which she had around 5-6 episodes of vomiting. And there was no and associated with the burning sensation in the chest and throat, lasting.
Just wait a minute. और वॉल्यूम क्यों नहीं आ रहा इसमें? नहीं, it is only coming in the laptop. Morning. Now can we?
Yes, sir.
Yeah. Go ahead.
Yes, the patient, she gave there's history of consumption of around 50 ml, following which she had 6 episodes of vomiting. And there was history of burning sensation in the chest and throat, which was lasted for about 1 day. And there was no history of any abdominal
Just
pain.
wait for a minute.
कम करने दो.
कम
करने दो.
अच्छा.
कम करने को थोड़ा.
नहीं, इको हो रहा था ना.
तो सर मतलब
नहीं, मेरे को तो इसमें सुनाई दे रहा है. तुम लोगों को अगर सुन रहा है तो ठीक है. हाँ, प्लीज कैरी ऑन. सॉरी, देयर वाज सम इशू हियर. स्टार्ट अगेन फ्रॉम द बिगिनिंग.
She is a 22-year-old female from Bijnor, UP. She presented with the chief complaints of difficulty in swallowing for past 2 months. There is alleged history of accidental consumption of toilet cleaner on 12th of September. She had consumed around 50 ml, following which she had 5 to 6 episodes of vomiting. And there is history of burning sensation in the chest and throat, lasting for about a day. And there is no history of any abdominal pain, hoarseness of voice, breathing difficulty, metamesis or melena. She was taken to a local hospital where she was admitted, and rice tube was inserted and lavage was done, and she was admitted. She was treated conservatively in the ward for 7 days. There was no any history of ICU admission or oxygen support. And rice tube was removed before the discharge, and she was on liquid diet after the discharge. She was taking on liquid diet for 1 month, and after that, after 1 month, she developed vomiting episodes, which was non-bilious, containing food particles, and 1 to 2 episodes of vomiting was there per day. And after a week later, she also noticed she also developed difficulty in swallowing for the liquid diet as well, and which gradually progressed over the next 3 weeks. And currently, she is able to swallow only saliva. For this complaints, she went to another hospital around 4 days back, where she underwent upper G endoscopy was done on OPD basis, and she was referred to AIMS for further management. There is history of weight loss or around 8 kg in last 2 months after this injection of Corrosive. Past history, there is no comorbidities, no issue of any prolonged medication, no issue of any previous surgeries, and there is no issue of any addictions or psychiatric illness or any suicidal attempts in the past. She is married since 1 year. There is history of spontaneous abortions at 6 weeks of gestation. That's 4 weeks, at the 4 weeks of gestation, and she is a nulliparo. To summarize my history, She's a 22-year-old female, sir, with history without any comorbidities, addiction, or psychiatric illness, presented with accidental ingestion of corrosive 2 months back. Now, she initially tolerated liquid diet, followed by recurrent episodes of vomiting and progressive dysphagia from grade 3 to grade 5 over the last 1 month, with significant weight loss, that is around 8 kg weight loss for the 8 weeks duration. So, with this history, this is a corrosive induced dysphagia, sir, and probably she also had a gastric cord obstruction along with the dysphagia.
Okay, let's go back to the second slide, the history of present illness. Accidental consumption. Are you convinced?
The history she gave, sir, it was a toilet cleaner which was kept in a
Yeah,
normal
so
water.
we know that the history is as given by the patient, but just as in symptoms, sometimes we have to ask leading questions because patients may not understand the importance of a symptom. Similarly, in case of a corrosive intake, we have to be very, very careful and cautious that whether it is truly accidental or whether it was intentional, because see, in our society and in any society, attempt to suicide is considered as a social stigma. So even if I have taken it intentionally, if I survive, I may not say that it was intentional. Also, what is the chronological relationship between this episode and the abortion? What is the date of abortion?
So that was like after this ingestion, and
So again, you have to be sure that it is after the ingestion, because if it is before the ingestion, that may be the cause. She is so depressed because of the abortion that she then resorted to this step. So you have to be absolutely sure of the chronological relationship. If there is a life-changing event, you have to make sure that they two are not related to each other. Okay. Then, okay. You said no history of abdominal pain. Why did you ask that?
sir, was there any uh, gastric injury after the corrosive, which would have led to perforation, to rule out the stomach perforation as per the.
Yeah. And hematemesis and melena?
Metamesis and melena is also associated more with the gastric injury, gastric corrosive injury rather than esophageal injury, sir. So,
GI bleed can occur in corrosive esophageal injury also, but it is more likely to be there in corrosive gastric injury. So if there is history of hematemesis or melena, you will keep in mind that there may be a possibility of a gastric injury. Do you agree with the management?
no, sir. They should not put a rice tube blindly, uh, and and they also done a lavage. So that should not have been done in
Yeah. So
acute corrosive.
both the steps, right? Placement of a rice tube blindly, which means without endoscopic guidance, and lavage are not recommended, in fact, contraindicated, because both can cause problems. So the fact that it was done and nothing happened is very fortunate, but it should not be done. Next step, suppose they had put the rice tube and she came to you with the rice tube, what would you have done?
We'll keep the rice tube in situ, sir.
Yeah, that
Reason.
also. The second part also, that they remove the rice tube, is not correct. First, they should not have put it. But anyway, if somebody has put it and fortunately nothing has happened, then you should not remove it. Why not?
Reason being, sir, if there is it can serve as a feeding access also. If there is only corrosive esophageal injury, and other one being it can act as a guide for future dilatation.
Can you increase the volume? So yes, one is that you can use it for feeding, provided there is no gastric outlet obstruction. And second is that it keeps the lumen patent. Even if a stricture forms, it will form to the diameter of the Ryle's tube, and the Ryle's tube you can use to place the guide wire for dilatation. So both the advantages are there. Okay, next slide. Okay. So first symptom, the vomiting, non-bilious vomiting containing food particles. What does it indicate?
Indicates a patient was taking liquid diet and she would have developed gastric outlet obstruction, which had led to vomiting episodes. And however, she was able to taking liquids and along with that, gradually she also developed dysphagia over next 1 week. And currently she's able to swallow only saliva.
Yeah, so as you rightly mentioned in your summary, she has both. She has symptoms of gastric outlet obstruction and she has symptoms of corrosive esophageal narrowing also. So probably both esophagus and stomach are affected. Okay, next please. Yeah, again, so you have to be very, very careful that you know the exact chronological relationship between this abortion and the episode of corrosive ingestion. Okay.
Yes,
Summary.
yes, to summarize, 22-year-old female without any comorbidities, addiction, psychiatric illness with.
Yeah, okay. So here in the vomiting, you should mention vomiting containing non-bilious food particles, because that would tell me that you are thinking of gastric outlet obstruction. That is important because patient may be having regurgitation, but she may say it is vomiting. You know that there is a difference between regurgitation and vomiting. A corrosive esophageal stricture, patient may have regurgitation, but that is not vomiting. So if you are sure that it is vomiting and if it contains undigested food, non-bilious, then you are thinking of gastric outlet obstruction. You said your impression is grade 5. How can you grade based on history alone?
So the dysphagia, if she is able to swallow solid diet, it is grade 0. Sir. Grade 1, there will be sticking sensation in the
Oh, sorry.
throat.
I'm sorry. This is grading of dysphagia. I thought you are grading the corrosive injury. I'm sorry. It's okay. Yes. She started having dysphagia. How much time after the corrosive injury?
That is 1 month later, sir. That is 4 weeks later, she developed dysphagia.
So is 4 weeks good enough time for a stricture to form?
Yes, sir. Usually the stricture healing phase starts after 3 weeks, sir. So 4 weeks it started having stricture formation.
Okay, we'll come back to that point later when we discuss the management. Yeah, please carry on.
On examination of the patient was alert, conscious, oriented to time, place, and person. She was sitting comfortably, and she was averagely built, poorly nourished, with a BMI of 16.8, and she had a pallor on examination, and there was a pedal edema noted, and vitals were stable with pulse rate of 90. On examination,
Please carry on. Carry on. Sorry.
On examination of oral cavity, oral hygiene was good. Adequate mouth opening was present with normal tongue movements. There was no mucosal lesions or scarring in the oral mucosa, and posterior pharyngeal wall was normal.
Go back to the oral cavity. So suppose I am taking you for a ward round. You have not taken the history of the patient. By just looking at the patient, a 22-year-old female, can you say or can you guess that she may be having a corrosive esophageal stricture?
Sir, usually patient will be malnourished, and if there is a grade 6 dysphagia, she'll be having a spitting. There will be bowel where the patient will be spitting. So,
Yeah, so a young female who's constantly or repeatedly spitting out her saliva in a spittoon, who's malnourished, emaciated, is very, very likely or most likely to have a corrosive. So in the general physical examination, because when you are examining the patient, you have spent a few minutes with the patient. During that time, if repeatedly she is spitting out her saliva, you know that she has a very severe esophageal stricture and she's not even able to swallow her saliva. On the other hand, if she doesn't do that and you know that this is a patient with corrosive stricture, then you know that at least she's able to swallow her saliva. That is one. In the oral cavity, good that you have mentioned all these points, but what are the other things which specifically in a patient with corrosive injury you should mention? Few more things.
one is the voice of the patient, sir. Is there
Sorry?
any is there any hoarseness voice?
Yeah, you mentioned posterior pharyngeal wall. What other structures may have abnormality or scarring, which you should specifically mention?
Tonsillar fossa, the
Yeah, tonsillar fossa, epiglot, mhm,
uvula.
uvula, yes, soft palate and uvula, because all these structures you mentioned, mucosa, even periorbital, perioral skin, lips, then the mucosa, oral mucosa over the tongue, over lips, over cheeks, and then the tonsillar fossa and the tonsillar folds, the posterior pharyngeal wall, the uvula, the soft palate, all these things, if you mention and examine, that tells me that you have looked for an upper aerodigestive tract injury in great detail. And similarly, you did mention in the history that there's no hoarseness of voice, but voice is both history and examination. When you are taking the history, you are hearing the patient. So here you can say that her voice is normal and she has no hoarseness. That confirms, okay?
Yes, sir.
So in esophageal diseases where or in corrosive injury, hoarseness of voice can be mentioned as a part of examination also. Okay, please carry on.
Abdomen examination, inspection of abdomen. Abdomen was flat. All the corresponding quarters moving equally to respiration. There is no visible peristalsis. There is no fullness. On palpation, abdomen was soft, non-tender. There is no free fluid, no organomegaly, and hernia requests were normal. Percussion, liver dullness started with fifth intercostal space, liver span of 12 centimeter in the right midclavicular line. The rest of the abdomen was tympanic and there is no free fluid. And auscultation had a normal bowel sound. Respiratory examination, trachea was central. There was bilateral normal vesicular breath sounds were heard. There was no added sounds. Cardiovascular and CNS examinations were normal.
If the patient comes to you immediately after the corrosive intake, what else in the examination of the patient would be important other than what you have mentioned here? Anything specific?
Respiratory examination is important. We have to look for signs of aspiration. Is there any bilateral basal crepes or
Emphysema, surgical emphysema in the neck. Okay, because if there is an esophageal such severe injury that there is a perforation, then you could have surgical emphysema in the neck, which obviously at this stage is not important, but in the acute stage, it is important. Okay. Yes.
Yes,
So, okay, diagnosis is you, but you are saying feeding jejunostomy and venting gastrostomy in situ. We didn't hear about it earlier.
oh, sorry, sir. Sorry, sir. I just
So the summary provided to you.
no, sir. It was unremarkable, sir. It
Yeah.
was.
So probably from some other. Okay. Fine. So there's no question about the diagnosis. Let's proceed. So she comes to you at this stage. What would you do?
Uh, Sir, now she is 8 weeks after the corrosive injection, sir. And on examination, she is malnourished because she is having pedal
I
edema
didn't
and she's
ask
having.
that. I asked, what would you do? There's no need to repeat what you have already said. Answer the question.
Uh, I would review her endoscopy report, sir, which she's got from outside.
Which report?
The upper J endoscopy report, which
Let's see.
she. Sir, it shows there is a distal caustic stenotic stricture is noted.
Before you describe, you have to say that this endoscopy is done so many days, so many weeks, or so many months after the injury, because that puts it in the correct perspective.
This endoscopy was done 7 weeks after the injury, sir. That is 1 week prior, 4 to 5 days prior, which shows there is a distal caustic stenotic stricture negotiated with slight dilatation. They have not mentioned how many centimeters away from the incisor, sir. And however, the scope was able to pass beyond the stricture, and the stomach fundus was normal. Body had a multiple ulcer with sloughing seen. There is also incissular diverticula, which is noted, and, and antrum, there are erosions, and there's a tight stricture at the pylorus, beyond which scope was not negotiated.
Okay. So what will
Uh,
you do?
so, sir, there is a yes, sir. So she is having, sir, there is uh, negotiable stricture, a scope negotiable
Again,
stricture.
I asked not the findings that you have already, I asked you, what will you do? So say what you
Uh,
will do. This is a very common mistake which all of you do in the exam. When a question is asked, you don't answer the question. You start saying something else. That is not correct. First, answer the question. I asked you, now you know the endoscopy report. You know the duration. What will you do?
I'll get a routine blood investigation, sir, to look for her. She is having pallor to look for hemoglobin status and also the albumin status of the patient.
Again, you are not answering. What will you do? You want to look at the blood reports also?
Yes,
Say,
sir.
I want to confirm her nutritional, although
Nut-
clinically we know that she's malnourished, she has pedal edema. So very likely that the parameters will show that she is malnourished, but still you want to confirm. Let's look at the blood reports.
Hemoglobin is 8.2, sir, with albumin of 2.7. The rest of the investigations are normal.
So what do you make out of this? You don't have to read the numbers. You have to tell me what do you make out of it. Numbers, even a nurse can read to me. You have to interpret it.
She's having anemia with hypoalbuminemia, sir.
So
So
she has pallor, she has hypoalbuminemia, and it reconfirms my clinical examination findings that she is severely malnourished. That's it. Now what will you do?
sir, I'll explain the patient regarding the condition and requirement of feeding jejunostomy for a nutritional support, and I'll
So your
consider for
answer should be that it is how much? 2 months since the corrosive injury?
2 months, sir.
Almost.
Yes, sir. Eight
Yeah.
weeks.
8 weeks after the corrosive injury. So the stricture has still not matured. And that brings us to the question which we discussed earlier. What is the time period required for the stricture to mature to its final level?
It takes about 6 6 months, sir, for esophageal
Yes.
stricture to.
So most of the fibrosis in any injury, whether it is iatrogenic, traumatic, corrosive, in most injuries, the fibrotic process takes about 6 months to reach the final stage, which means that if you decide the treatment before 6 months, you are deciding at an incomplete stage, at a stage where the stricture can further progress. Kulbhushan, you are there. Please feel free to add anything in between. Dr. Kulbhushan?
Yes, sir, I am here.
Yeah. Please feel free to ask him anything or add anything between. Yeah,
Sure.
you should
Yes,
actively participate as faculty in these discussions. Yeah, thank you. So, Vinay, yes. So 6 months. So this is only 8 weeks. So your answer should be that it is only 8 weeks after the corrosive injury. The stricture has not yet reached the final stage or level, and she is severely malnourished. So at this point in time, the aim of treatment is only to provide nutritional support to improve her nutritional status. That is the plan of management. Next is how you will do it. So you said you will do a feeding jejunostomy. Why
Yes, sir,
feeding
feeding
jejunostomy? Why a surgical procedure?
So because uh, because she had a severe pyloric stenosis, so placement of nasojejunal tube is not possible, sir. And she's having multiple ulcerations in the stomach, and there is also diverticula in the incisura. So there is chances of perforation. So I would like to consider surgical feeding jejunostomy.
So the options of providing nutritional support in a corrosive injury or a evolving corrosive stricture can be tube feeding, enteral, or which means nasogastric or post-pyloric, or it could be a feeding jejunostomy. Now, nasogastric obviously is out in this case because there is gastric outlet obstruction. So she will not tolerate nasogastric. The only option is placing a tube across the pylorus. But the scope did not go, but maybe a guide wire will go across the pylorus because it is only 8 weeks. It may not be a completely tight or obliterated stricture. So that you can decide either by trying to pass a guide wire across the pylorus, or you can do under fluoroscopy with contrast. And if a guide wire goes across the pylorus, one option is a nasoduodenal or a nasojejunal tube for feeding. But obviously, the advantage is that you don't need a surgical procedure. The disadvantage is that it is inconvenient or uncomfortable to the patient because this tube is going to remain for a long time. She will take a few weeks, maybe a couple of months to achieve a normal or near normal nutritional status. Okay, so but you must mention that these are the options, and that brings us back to the discussion that we had, that if at all a rise tube has been placed, you should not remove it, because suppose she did not have gastric outlet obstruction, that rise tube could have been used for providing enteral nutrition. Similarly, when an endoscopic evaluation is done, most endoscopists will place a rise tube again with both those aims. But obviously in this case, because there was gastric outlet obstruction, they did not do it. So in this case, yes, practically speaking, a feeding jejunostomy is an option. Okay, was it done?
No, sir, yet to plan for. She is posted in another one.
Okay. What about a contrast study? Would you do a barium or a gastrographin swallow or a meal?
Yes, sir. Barium swallow and meal was done, sir.
Before or after the endoscopy?
So this was done in our institute, sir, after the endoscopy.
Why?
We had done endoscopy outside.
Why do you need a barium study?
Actually, it should have.
After the endoscopy, why do you need a barium study? What extra information you are trying to get?
The endoscopy did not mention at this point, it will not change the management, sir. It should have done prior to endoscopy as a roadmap for endoscopy.
Yeah, so if you have already done an endoscopy, the only other information that you will get from a contrast study is the point I was mentioning earlier, that whether any contrast is going beyond the pylorus or not, in case you want to use a nasoduodenal or a nasojejunal tube for feeding. Because if contrast is going, then probably guide wire also will go, and then you can place a tube. That is one. Second, if you it will show you any perforation, although it is 8 weeks, unlikely that it is there. But then if you did suspect a perforation, obviously you should not have done the endoscopy. More important is that most endoscopists for a corrosive stricture would want to have a contrast study as a roadmap, because in these patients, there is usually deviation of axis. And deviation of axis is something which is very dangerous for the endoscopist, because the endoscope goes in a straight path. But if there is a deviation of axis, it can cause a perforation, a nitrogenic perforation. So that is why they want to know what is the lie, what is the axis of the esophagus. And there was another point mentioned in the endoscopy. Go back to the endoscopy report. Yes. What is it that we haven't discussed? Something mentioned.
It's a
What does
diverticular.
Yes.
The presence of incisura diverticula is there in the.
Yeah, diverticulum. The diverticulum is in the esophagus or in the stomach?
In the stomach, sir, at the
Stomach.
level of.
Okay. Stomach, it is not that important. What do you think this diverticulum is? Suppose you say,
gastric diverticular, sir, because of gastric pyloric stenosis.
Yeah, it may be a coincidental finding, but in esophagus, in corrosive injury, especially when the stricture has evolved or is evolving, you can see what are pseudo diverticuli. So they are not true diverticuli. And that again is dangerous, because if the scope enters a diverticulum, it is again likely to perforate it. So another reason why the endoscopists want a barium study before they do an endoscopy. Okay. So anything else has been done at this stage for this patient, or that's it?
That's it, sir.
Okay.
And
now let's presume that after how much time you want to wait? We have done a feeding diagnostomy. We are providing her nutrition. When do you want to decide what to do?
Sir, after feeding gastroenterostomy, we'll put her on endoscopic dilatation, sir, regularly. That is 2 weekly for esophageal stricture management. And if she achieves around 14 mm of dilatation, 15 mm, then if it stays stable for at least 4 weeks, so then we'll consider for gastroenterostomy after 3 months. That is after
so
3 months of
you want to dilate the esophagus or the pylorus or both?
Sorry, dilate the esophagus, sir, and both. If pyloric dilatation is also possible, then that also would be.
Yeah, so dilatation can be done for both, for esophageal stricture as well as pyloric stricture. And for dilatation, you don't have to necessarily wait for 6 months. 6 months waiting is for surgical management, because even now there is some inflammation, there is some fibrosis. So as long as there is no risk of perforation, which means that the acute corrosive injury phase is over, you can start the dilatation. And both esophageal and pyloric strictures can be dilated. And they can be managed. So you describe the schedule. How do you define that dilatation is successful?
Sir, able to achieve 40 French of or 14 of diameter and it remains stable for at least 1 month, then we'll consider it as successful dilatation.
Yeah. So after the last dilatation, when you repeat the endoscope, one is that clinically the patient should be able to, suppose, let us for the moment disregard the pyloric stenosis. Let us presume that pylorus is normal. It is only esophageal injury and stricture. So you dilate the esophageal stricture every 2 weeks, and following the last dilatation, if the patient is able to swallow, you should demonstrate that 4 weeks, at least 4 weeks after the last dilatation, a diameter of 14 is maintained. That would define as success of dilatation. And then you have to follow up, because even if the dilatation is initially successful, because as we discussed, the fibrotic process continues even beyond 8 weeks or 12 weeks and can go on till 6 months. So there could be a reef stricture formation, and that is why close follow-up in terms of dysphagia status and endoscopy is important, and the patient may require repeat intervention. Okay?
Yes, sir.
What are the factors which decide whether dilatation is likely to be successful or likely to fail in esophageal stricture?
Yes, sir. Sir, if it is a multiple strictures, then if it is long segment strictures, then associated with diverticulae. So these are the strictures which are more likely to fail.
Diverticulum doesn't decide the success or failure. As we discussed earlier, diverticulum makes it technically difficult. The endoscopist has to avoid the scope entering into diverticulum. If he can do that, it doesn't decide the success. It is only a risk factor for complications. So length, yes. Multiplicity, yes. And the tightness of stricture. Okay. These are the factors which will decide whether dilatation is likely to be successful or not. Okay. Let's presume that, so suppose endoscopic dilatation is not successful, either for esophagus or for pylorus, and you decide that surgery is required. At what stage would you advise or would you consider surgery for this girl? What will be your criterion that now I can operate upon her?
Yes, sir. So if the endoscopic dilatation has failed, then after nutritionally optimization of the patient with the enteral feeds, then I'll wait at least for 6 months. Then I'll again get an endoscopy done. Is there any ulcerations or still inflammatory process persisting? If there is a fibrosis is there, and then I'll consider after 6 months, I'll consider for definitive surgery, sir. That is by either colonic conduit.
There are two factors which decide. One is the duration, because as we discussed, fibrotic process can go on for 6 months. But suppose at 3 months, endoscopic dilatation is either not possible, or it has resulted in a complication, or it is not successful, and you are anyway going to do surgery. It doesn't matter, because anyway you are going to provide an alternative conduit, so you don't have to necessarily wait. 6 months waiting is if, for example, in this case, suppose the initially she did not have gastric outlet obstruction, but there was some corrosive injury to the stomach. Whether that stomach can be left without any drainage or resection, for that you have to wait for 6 months. Similarly, whether you have to do surgery or not, to decide that you have to wait for 6 months. But if surgery is indicated otherwise, you don't have to wait, because anyway, either you are going to remove the strictured part or you are going to bypass it. So even if more stricture forms later, it doesn't matter. So one is the duration. Second is the nutritional status. So you said once she is optimized. What do you mean by optimized?
That is improving inner weight along with albumin of at least more than 3.
So you should say objectively, you should say that she has lost 8 kg. I would want her to at least come back to her previous weight or near that weight. She should be gaining weight. Gaining weight is more important because that means that you have come out of the catabolic state. Once the patient starts gaining weight, that means you are moving away from the catabolic phase. And a hemoglobin of at least 9, preferably 10 or even 12, albumin level of at least 3, preferably 3.5 or above, no pedal edema. That is how you say that she has been nutritionally optimized. So again, going back to the duration, I hope I have made myself clear. 6 months is the time of maximum fibrosis. So if you are not going to operate on a stricture, that decision you cannot take before 6 months. Suppose today you decide that she doesn't require surgery 3 months, but she may require intervention at 6 months. On the other hand, if 6 months have passed and there is no stricture, then it is very less likely that a stricture will form. On the other hand, if there is an indication for surgery even before 6 months, not necessary that you wait for 6 months. Then you can operate at 3 months, 4 months, once optimum nutritional status, as we discussed, has been achieved. Now, in this particular case, let us presume 2 hypothetical scenarios. One is that her esophageal stricture responds to dilatation. She is able to swallow soft food or almost normal food, but the peptic stricture persists, which means that she can swallow, but she vomits. What will you do?
Yes, I'll consider her for gastroenterostomy as a procedure of choice.
Why
After
gastroenterostomy? Is that the only option?
So we can, if there is pyloric, pre-pyloric stricture alone, then we can also consider other option will be the excision and anastomos, gastroduodenostomy, that is Billroth one. That is also.
So why did you choose gastrojejunostomy? First is, in the first instance, you should have said that there are 2 options, but I will choose this because the moment you said only gastrojejunostomy, I think that you don't know about the other options. So when there are options, first you should mention the options and then you should say, I will choose this option. So your answer should have been, there are 2 options of surgical management of a peptic corrosive stricture. One is excision or resection with Billroth, 1 gastroduodenostomy, and second is leaving the stricture behind and doing a bypass in the form of a gastrojejunostomy.
Yes, sir.
And if you are doing a gastrojejunostomy, is it gastrojejunostomy alone? Do you do gastrojejunostomy alone in a benign disease? What are the problems?
Gastrojejunostomy with the
What are
feeding
the
jejunostomy.
what are the 2 common complications of gastrojejunostomy? One immediate and second late.
One is delayed gastric emptying.
No. What is the commonest complication of any operation on the stomach? Immediate, major complication. Cystogastrostomy, gastrojejunostomy, even gastrostomy. It's bleeding because it's such a vascular organ. What I am referring to is that if you do a GJ alone for a benign disease, there is a very high risk of anastomotic or stomal ulcer. Although you can argue that here the gastric mucosa has been destroyed by the corrosive, but not all gastric mucosa would have been destroyed. There will still be some pyloric enteral mucosa. There will be still some acid secreting mucosa. So acid secretion would continue. And therefore, when you do a GJ for a benign disease, as opposed to a malignancy, where life span is short, you always have to add a vagotomy. So it has to be vagotomy with GJ. Okay, coming back to why not enterectomy or pylorectomy and a Billroth 1 GT?
Because, sir, though the duodenum is unlikely to be involved with a corrosive injury, but since we not know the status of the duodenal injury, sir, because scope was not able to pass beyond. So since we don't know the disease status of duodenum, so we'll consider for gastroenterologist.
Is duodenum likely to be involved in a corrosive stricture?
So unlikely, sir, but still
Very
there will be.
unlikely, because the moment the corrosive reaches the pylorus in the acute phase, the pylorus goes into spasm. It doesn't allow the corrosive to go into the duodenum. So very, very unlikely that duodenum will be involved. And therefore, the resection of the peptic pyloric stricture is always a technical feasible option. So why people do a resection? Why they don't follow your philosophy that do a bypass? What is the reason? You should have said that that is technically more demanding. This is a much easier procedure, bypass. So that is the point in your favor. But those who do a resection, why do they do resection?
So that will be more physiological, sir. Billroth 1.
For that is not the reason. That is an advantage.
And
The reason is
malignancy.
So the
risk
risk
of
of malignancy, the
malignancy.
same thing held true for esophageal corrosive stricture, because it was felt that there is a higher incidence of malignancy, and that is why both corrosive esophageal stricture and corrosive pyloric stricture, people used to do resection. So the reason was resection. The advantage is that it is physiological, and the point is that duodenum is very unlikely to be involved. So you will have a soft, supple duodenum where you can do a Billroth 1 gastroduodenostomy. But more and more people believe that, at least in stomach and to some extent in esophagus also, that risk of malignancy was probably overstated. It was an overestimation, and it is not that high. So that is why not many people would do a resection either of a esophageal or a pyloric stricture. They would just do a bypass. The other problem in resection would be that if there is extensive injury of the wall, there may be periviscous inflammation, fibrosis, and adhesions. And technically, excising a pyloric stricture may become difficult and may cause injury, say, to pancreas, bleeding. In severe cases, there may even be scarring around the lower part of the or the retroduodenal part of the bile duct. So you may cause bile duct injury. One of the, after cholecystectomy and choledocholithotomy, the third common cause of a bile duct injury is operations on the stomach, especially the pylorus and duodenum, because the CBD lies just behind. So if there is peri-pyloric scarring, you could cause injury to the pancreas and to the CBD. So that is why more and more groups would do a bypass procedure. Okay, let's presume the other scenario, that the pyloric stricture somehow has resolved, or it is not much, or she did not have any pyloric stricture, and the esophageal stricture is not responding to dilatation. So when would you operate? There was some corrosive injury to the stomach, but endoscope is passing through the pylorus, but the esophageal stricture is not responding to dilatation, or it responded and it came back. And she is about 4 months.
Yes, sir. Now, my procedure of choice would be using the esophageal bypass, sir.
Timing?
Timing, sir, that is 6 months.
Yeah, so this is the situation that I was referring to, that if you are leaving the stomach intact, not doing any procedure on the stomach, thinking that pylorus is functioning normally, you cannot operate upon this patient at 4 months or 3 months or 5 months. You must wait at least for 6 months to make sure that the stomach injury has healed without causing any narrowing. Because if you do an esophageal bypass now, and after 2 months, the pylorus now shows a fibrotic stricture, you will be in a soup. So if you are leaving an injured organ behind untouched, you have to wait at least for 6 months. Okay. Same is true. If suppose esophagus responds and pylorus is not responding, then you should wait for 6 months to make sure that esophagus is not going to stricture further and you have to deal surgically only with pylorus. But if there are indications to deal surgically with both, you can go in early because then you are not leaving any injured organ, corrosively injured organ, untouched behind. So now you understand the
Yes, sir.
importance of 6 months. Okay.
Understood.
So fine. You said esophageal bypass. Again, the same thing. You should have said that there are two options. One is resection of the corrosive stricture and replacement of the esophagus. And second is leaving the stricture in situ and bypassing it with a viscous. And the arguments are same. Anything else in favor or against resection or bypass? Any other points in favor of resection? One is malignancy. Any other point in favor?
Other one is there is chances of mucocele, sir, which can develop if there is multiple strictures.
So second point, yeah, that if you leave the strictured esophagus behind, it can rarely, these are case reports, form a cyst in the other point is that if you resect, you will be using the posterior mediastinum, which is the shortest route. So you don't need a long conduit and it is the physiological route. Whereas if you're doing bypass, obviously you will have to use a substernal route, which is a longer route and is not physiological. What is the disadvantage of a resection? Why more and more people have moved away from resection? One reason we said that the risk of malignancy was overestimated. Any other reason?
And second being because of peri-esophageal inflammation and dense scarring adhesion, there will be increased chances of tracheobronchial and major vascular and thoracic duct injuries.
Yeah, not inflammation. Now you are doing it after a few months. It is scarring. So peri-esophageal scarring and adhesions because of the inflammation which happened at the time of corrosive injury. And here, the most important organ or viscous is the tracheobronchial tree. Because if the esophagus lies behind the trachea and the bronchus, so it is the membranous part of the trachea. And if there's any adhesion there, it's like a choledochal cyst with cholangitis, having pericholedochal inflammation and the portal vein lying behind, thin-walled structure. So if you dissect there, you can cause injury to portal vein. Same way, if you are doing a dissection around the esophagus in a corrosive injury with periesophageal fibrosis, you can very easily cause injury to the membranous part of the trachea or the left bronchus. So these are the two reasons that the risk of malignancy was overestimated, overstated, and there could be periesophageal scarring, which increases the chance of tracheobronchial injury that people have moved away. Most people have moved away from resection to bypass. Okay, you said bypass. What will be the organ of replacement?
Again, there are two options: stomach and colon. But colon is what is most preferred in corrosive esophageal injury.
Why?
Because stomach can also get injured in the process, so that diseased stomach we cannot use as a conduit. That is one reason. And second being, there is increased chance of acidic reflux with using a stomach as a conduit. These are the two reasons.
Yeah, I think there will be difference of opinion. There are some groups which still would use the stomach. There are others which say that for benign disease like corrosive, they would prefer colon because they want to keep the stomach as a food storage area. There are points in favor and against. Points in favor of stomach are that it is a very vascular organ. Vascularity is very good. So chances of any ischemia of the conduit, and consequently the leak are less. As far as the risk of reflux is concerned, reflux is more if you do the anastomosis in the chest. But if you're doing a bypass, obviously you will be doing anastomosis in the neck. In the neck, the chances of reflux are less. The other advantage or disadvantage of colon and indirectly advantage of stomach is that with colon, you will end up with 3 anastomosis: an esophagocolic, cologastric, and a colocolic. Whereas if you're using stomach, then you have only 1 anastomosis. And so, okay, if you use stomach, what do you do to the pylorus?
We'll do can add a gastrojejunostomy as a bypass, sir, or
No, not in this. I'm saying in general, suppose esophageal stricture only, stomach is normal. You're doing a gastric bypass for an esophageal stricture. What do you do to the pylorus?
pyloroplasty or dilatation of the pylorus can be done.
So again, there are several options. Different groups use different options. Starting from doing nothing, there are groups which do nothing to the pylorus. Then you can do an internal dilatation either with finger or with Hagas or with a TUBS dilator or a balloon. There are groups which disrupt the pylorus permanently, either as a pyloromyotomy, what you do in hypertrophic pyloric stenosis, and rarely there are groups which would do a formal pyloroplasty. So it ranges from doing nothing to a formal pyloroplasty, and there are points and favor and against. Okay, so these are questions which obviously will be asked. And the last thing which you will be asked if you are using colon is that which colon, which part of colon?
Either we can use right colon or the left colon, so each has got its advantage and disadvantage. But most group will prefer left colon because of its constant vascularity and the diameter of the colon, which is
yeah. So in the right side, there are more variations of anatomy which are less on the left side. The lumen of the left colon matches the lumen of the esophagus better. Right colon is more in diameter, and that is why most groups use left. And if you are using right, any modification, anything which some groups would do? What do you anastomose to the esophagus if you are using the right colon?
Use the ileum.
Yeah, so
ileum.
there are people who would take a few centimeters of the ileum, preserve the ileocecal wall, and do an esophago-ileal anastomosis. Again, for 2 reasons: the lumens may be same or similar, and you have some kind of a valvular function, but that is very, very debatable. So some people would do ileo right colon conduit, doing an esophago-ileal and then a cologastric anastomosis. Okay. So these are questions which obviously will always be asked in a corrosive injury, that what is the management on the acute stage? When do you do endoscopy? Why you do endoscopy? As an alternative to endoscopic evaluation, now more and more groups are using contrast enhanced CT to avoid the risk of endoscopy, whether you place a Riles tube or not, how long you wait for definitive treatment, and then obviously what definitive treatment. So students, please send me a mail, vkkapoor.india@gmail.com, write esophagus. I will send you the chapter on esophagus from the operative surgery book, which is on Kindle. But now onwards, I cannot provide you chapters from the clinical surgery book because that book has already been published. And if I do that, I will be violating the contract which I have with the publisher. So from now onwards, I will send you only the operative surgery chapters. Dr. Ankit wants to know pre-op evaluation for colon conduit. Vinay, you want to attempt to answer that? What all do you do?
We'll get a seat in our Though it is not routine recommended, sir, but in our institute protocol, we'll get a routine colonoscopy and a CT angiogram before colonic conduit for all the patients.
Yeah, so again, there are groups which would do nothing if the patient has no colonic symptoms in the history. To the other extreme, as you said, that they would like to evaluate the mucosa by doing a colonoscopy and a CT angio to evaluate the anatomy. But as Dr. Ankit again asking, is it required in all patients? No, it depends on the group's philosophy that whether you do an angiographic evaluation or not, because as we discussed, the variations are more on the right side. Left colic artery is almost always there with its ascending and descending branch, and that is what you base your left colonic conduit on. So some groups would not do any evaluation. Some groups would do a colonoscopy only if it is an elderly patient to rule out a colonic pathology, not in a young patient. And some groups would do a colonoscopy and a CT angio in almost all patients. About the colonic conduit necrosis, I think that's a separate topic in itself. Again, I would say that Vinay, if you want to discuss the operative surgery part of esophageal replacement, because we just asked very few questions related to that, then you can prepare that. And the preparation for that would be indications of surgery, timing of surgery, options, as we discussed, resection versus replacement, pros and cons, and then the technique and complications. So if you want to do that, let Dr. Anand know, and then we will have a separate session. Ankit says, yes, this is very important. Respiratory optimization in the form of incentive spirometry and other measures from the day one that the patient comes to you, because that is the most important thing. These patients do have frequent regurgitation and aspiration and recurrent chest infection, and that becomes a very frequent problem in the post-operative period after any esophageal surgery for that matter. So all these things are there in that chapter in more details. You can all go through that. Okay, thank you. Thank you, Vinay. Thank you very much.
Thank you, sir.
Thank you.